So we're going to move on now and talk about mitochondrial therapies and remedies. You might think this is a bit early to be discussing these, but there's a good reason for it. And that's because the slides are not working. Right, okay. But I know that we've had a few people join over the coffee break or just before. So I'm just going to remind you about my slides and inform those that I didn't get to talk to before. So there's so much information on mitochondria. I'm not lecturing everything on my slide, only the green bits. Please follow me through as I speak and don't try and read the slides now because I will lose you and that would be so sad. My website has got more material on, and that's everything with a red title. Right. So now how I'm approaching all of this is because clinical mitochondrial therapeutic research is still in its infancy, there are very few studies, in fact, almost none, which show that a particular therapy or remedy works through the mitochondria to benefit people with chronic disease. So I'd love to be able to show you that, but I just can't. So I've had to take a slightly different approach, which is as follows. I am establishing the principal mitochondrial, or rather the principal therapies and remedies which benefit mitochondrial function. And then I'm looking at those mitochondrial therapies and remedies to see if they also benefit chronic fatigue patients, or not chronic fatigue, any chronic disease patients. So that's how I'm approaching this. And when I came to select which chronic diseases I'm talking about today, I could have gone for, I don't know, about 40 of them and had about 2 seconds on each, but I didn't think that would be very interesting for you. So what I've done is I focused on metabolic disease, neurodegenerative disease, cardiovascular disease, cancer, and autism. And so that I can spend a little bit longer on each one of those. So I hope that's all right. Now, I'm going to be talking about a lot of therapies and remedies here. If your favorite therapy or remedy is not amongst them, please don't worry. Doesn't mean it doesn't work. All it means is that there aren't the studies to support my being able to talk about it today, because everything that I'm talking about is evidence-based. Right. So these are the therapies for which there is good evidence that they actually can improve mitochondrial function. And so the diet, we've got caloric restriction, fasting, ketogenic diets, all good. Exercise, any exercise is good, but endurance exercise is better than resistance. And high intensity interval training is also fantastic. Hyperbaric oxygen, therapeutic hypothermia, and sometimes I'm also talking about hyperthermia, not just hypo. Near infrared radiation, which works via chromophores, and in the mitochondria, our chromophore is cytochrome C oxidase, which is complex 4 in the electron transport chain, and pulsed electromagnetic fields. So these are all beneficial for the mitochondria at moderate dosage, but don't use them too much, or because they can become toxic. Right. So I look very carefully for studies of vegetarian and vegan diets, and I'm afraid I didn't find a single one. So I really can't talk about them. But with vegan diets, we do have some mitochondrial issues, and to a lesser extent, vegetarian issues. There is a liability to be deficient in all of these micronutrients. And to paraphrase Dr. Jenny Goodman, who you're hearing from later, and Queen Elizabeth I, I may have the soul of a vegan, but I've got the body and the brain of a carnivore. So, so the care and feeding of the mitochondria is very important. And this is now when I can stick up my picture of cute puppies. So there they are. So They need real food, but not too much of it. They need clean water, plenty of exercise, no toxins in food, water, or air, and lots of TLC. But while I'm on the subject of dogs, beware the inner Labrador. Now, if you've read anything by Dave Asprey, you'll know what I'm talking about. But if you don't, I'll explain. Anybody who has known a Labrador will know that they are relentlessly and permanently ravenous. This is because they have a POMC mutation. Fortunately, humans don't have one. But we do have an inner Labrador, which is what Dave Asprey is referring to, which wakes up whenever we put the cells under stress. So that can be fasting or time-restricted eating, or we have a blood sugar dip, anything like that. We get the inner Labrador wakes up and it's got to be fed. Now, we don't have to give in to that, obviously, but we do need to discuss with our patients strategies for avoiding giving into it. And my strategy is really very simple. It's coffee. Because coffee is actually, despite having had a very bad press in recent years, it's actually extremely good for the mitochondria in all these ways. I won't bother to go through them. You can read it at your leisure. So, and it's a good idea not to stick with just one therapy, but to combine them, to alternate them. Because once the body gets used to something like, oh, it's hyperbaric oxygen time, the benefit tails off. I'm not saying there isn't any, but the body gets used to it and anticipates it. So never stay on any regimen indefinitely, because adaptation here is not a good thing. That's the therapies, which I shall be talking about later. Now the remedies, and you can see there are hordes of them. I couldn't believe it. I tell you, I was thankful for this delay in running Mitochondria Day. Really, it gave me a chance to research all these remedies, which otherwise I would not have been able to do. So these are all the studies are shown in Annex A, fully referenced. You can look at those. So obviously not all of these are going to crop up as being beneficial in all the chronic diseases that I'm talking about, but a fair few will, which is good. So I just want to say one final word about this, which is hormesis. So this is literally what doesn't kill us makes us stronger. So what is it? It's any process in a cell that exhibits a biphasic response. So this is a biphasic response. You've got increasing dose, you've got the response going up there, turning the corner and coming back down again. That is biphasic. So we often see this in toxicology, where you've got a low dose benefit, but in high dosage, it's a poison. And that's seen often as this inverted U-shaped curve, but also sometimes a J-shaped curve as well. And this is not unknown in conventional medicine. In cardiology, for example, it's known as preconditioning. So fine. And mitochondria are particularly, they particularly benefit from hormesis. They really like this for some reason. And what the mitochondrial therapies and the remedies that I just showed you often do is they induce hormesis, and that is how they benefit the mitochondria. Low levels of reactive oxygen species, which are wonderful signaling molecules. So they upregulate all kinds of things, both in the mitochondria and the cell. So all good. Right. So where we are upregulating or where we're inducing low levels of reactive oxygen species, we really shouldn't be giving antioxidants, because they're just going to negate the benefit of whatever therapy we're providing. So I don't really hate antioxidants, but it does sound like I do. I realize that, and I'm going to be against them on another occasion as well. Anyway, that's that. Now let's move on to metabolic disease and see how our mitochondrial therapies and remedies stack up to help patients with metabolic disease. So what am I talking about here? Well, I'm going to cover obesity, insulin resistance, type 2 diabetes, the slides for type 1 diabetes on my website. And then following this, we've got a lecture from Professor Ea Pirinen on mitochondrial function in obesity. So that'll be great. So because there are more studies for metabolic disease and mitochondrial function than any other chronic disease, I've been able to do something here which I've not been able to do in any of the others. And that is look to see whether mitochondrial dysfunction causes the chronic disease, or else the chronic disease causes mitochondrial dysfunction. So we'll see how that pans out. First of all, how is conventional medicine coping with the obesity epidemic? And the answer is really not at all well. And that's because they're still focused on low-fat, calorie-controlled diets. And my Annex C on the website gives you a lot of the studies which show that they just don't work. So mitochondrial dysfunction is routinely found in obesity, as you might expect. Does obesity cause mitochondrial dysfunction? Well, yes, possibly it does. And I've got several studies here which show that this may be the case. Does mitochondrial function cause obesity? Again, possibly. A few studies show that this might be the case. Let's look at insulin resistance. Mitochondrial dysfunction is routinely found in insulin resistance. Does mitochondrial dysfunction cause it? There's fairly clear evidence that in animals it does. So that's quite interesting. But is the reverse also true? Does insulin resistance cause mitochondrial dysfunction? Well, I only found these two studies, and the answer has to be just a maybe. Not enough studies yet. Type 2 diabetes, how is conventional medicine coping? Not well. And that's because they're focused on lowering fasting glucose and improving glucose tolerance. And there's nothing wrong with that. But it doesn't get to the root cause of the diabetes. So there's a limit, really, to how useful that's going to be. This was the case for many years until we came across Professor Roy Taylor at Newcastle University. Now, I don't know if you're familiar with his study. I heard him talk when I was at my job in Sweden, and he came to speak at a conference. So I went to talk to him afterwards. So it was great. So he described this study. He took some diabetics who were not on insulin, and he took them off all their glucose lowering medication, and he gave them a commercial liquid diet formula. It's something like, is it eSure or Ensure or Ensure? Okay. Oh yes, eSure. That's Michael Winner's insurance company, isn't it? Sorry. So after 12 months, there was mean weight loss of 10 kilograms. After 24% lost more than 15 kilograms, and 46% went into diabetes remission. That is pretty amazing. And despite the fact that this was a very expensive study, because for an entire year, all meals, well, more than, yes, a year, all meals had to be provided for all participants on the intervention. Nevertheless, it was cheaper than treating the type 2 diabetics. That's pretty shocking, isn't it? So the NHS was so excited, they started running their own study on this. I've no idea the outcome. Now, if you're disappointed, as I was, that Roy Taylor had to use a commercial liquid diet replacement, he was too, frankly, although you'll never hear him say this publicly. But the fact was, unless he used this commercial formula, he couldn't get ethics approval, and nor could he get funding. So he thought, okay, well, better to just run the study, see if it works, and then once I've got a track record, maybe I can do a bit better next time. So that's what he did, and well done him. Right, so mitochondrial dysfunction is routinely found in diabetes, no surprises there. Does mitochondrial dysfunction cause diabetes? Well, yes, possibly. Quite a lot of studies coming through here. Does type 2 diabetes, mitochondrial dysfunction contributes to diabetes complications? So even more certain there, I've given it a probably, so there must be good evidence. But does type 2 diabetes cause mitochondrial dysfunction? And frankly, I found no studies at all, so I couldn't possibly comment. But anyway, what's going on here? Because we've got a real mixture. We've got metabolic disease may cause mitochondrial dysfunction, but on the other hand, mitochondrial dysfunction may cause metabolic disease. What's happening? So I came up with 5 possible reasons why this might be the case. You can probably think of another 5. So you can tell me at question time. So my reasons are, firstly, there have not been enough studies yet to demonstrate a reliable direction of causality. Because if you run 8 studies, they're never going to come out with the same answer. There's always going to be 1 or 2 that are different. So that's possibly true. There's a confounding factor. So it's some other factor which hasn't been identified yet that mediates both relationships, like smoking, for example. I don't really think that's the case here. Direction of causality varies by tissue type. Yes, that's certainly the case. What happens to mitochondria in neurons, for example, is completely different to what happens to mitochondria in the pancreas. So if you've tested the wrong tissue, you're going to come up with the wrong result. But not all the researchers know that. There's an element of adaptation, yes. When the body senses something is going wrong, the mitochondria immediately upregulate function, which is great because they're trying to get you over the problem in the hope that the problem will go away and then they could just relax back to normal. So if you test the mitochondria in the early days of disease, you're going to find that there's mitochondria are working fine, working overtime, in fact. It's only later that you will find mitochondrial dysfunction. So testing at the wrong time can show that. And my other reason is that actually both are true because you've got a positive feedback loop or a feed-forward loop. So how would that work? Well, let's start with mitochondrial dysfunction. So that causes the diabetes. The diabetes causes further mitochondrial dysfunction. That causes worsening of the diabetes, which causes further mitochondrial dysfunction. So I think that's probably the most likely scenario, but it'd be interesting to hear what you think. So interestingly, most conventional treatments for obesity and diabetes use mitochondrial pathways. And of course, the obvious one here is metformin, which inhibits complex 1. But all of them that I've got listed here do something on the mitochondrial pathway. So I want to have a quick word about metabolic inflexibility now, because this is a term that's tossed around in webinars and blogs and so on. And I want to make sure that we are clear on what it means. So in metabolic flexibility, the mitochondria can switch freely between fuel choices. So it's Thursday, so they're processing fatty acids, and are perfectly happy on Friday to then process glucose, and back again on Saturday to fatty acids. That is metabolic flexibility. Inflexibility normally crops up when you've got, people who are eating too many carbohydrates and virtually no fatty acids. So that is inflexibility, where the mitochondria get stuck in just processing one fuel source, and then you present it with a fatty acid and it says, hang about, I don't recognize this, sorry. So that's that. So what I wondered then was, if you are a very keen ketogenic diet addict, could you get similarly stuck in processing fatty acids or ketones so that when you encounter some glucose, you can't produce energy from it? And I don't know the answer to that. And I don't think there've been any studies because people haven't been doing ketogenic diets for that long. But several practitioners, including actually Dr. Nicoll, do now advocate a cyclical ketogenic diet with adding in some healthy complex carbohydrates just to keep the flexibility. So that's quite interesting. Now let's look at our metabolic therapies for mitochondrial therapies for metabolic disease. So we've got caloric restriction and intermittent fasting. Great. more effective for weight loss than exercise. Ketogenic diet, brilliant. More effective for weight loss than a low-calorie diet or a conventional anti-diabetic diet. Exercise, not much effect on weight, but great for insulin sensitivity. Oxygen therapy, ditto for insulin sensitivity. Extreme temperature therapy, and they're both hot and cold, are good. Pulsed EMFs apparently are great for diabetic foot ulcers, so that's quite useful. And infrared radiation also quite good. So while we're on the subject of cold exposure, I'm going to mention about brown adipose tissue. So brown adipose tissue is actually brown because of the high concentration of mitochondria in it. And mitochondria are brown because of the high iron content. Remember those iron sulfur clusters in complex 2? That's this. So the brown adipose tissue, this is what converts energy from food into heat via UCP1. Do you remember we talked about the uncoupling proteins? And white adipose tissue, though, stores energy as triglycerides. So they're doing completely different things there. So it used to be thought that it wasn't possible to increase your brown adipose tissue. What you had as a young adult, you kept. But no, now we can. And this both improves metabolic function and insulin sensitivity. So the white adipose tissue can in fact take on the characteristics of brown in a process known as browning. Nothing very innovative there. And that creates beige or bright from brown and white adipose tissue. And the principal means of inducing this is actually cold exposure. There are some supplements that can as well, particularly things like bioflavonoids, but cold exposure, brilliant. It's free. So mitochondrial remedies with good evidence for benefit in metabolic disease. And you can see we've got a lot of them, which is great. So I've done a top 10 for you with dosages where applicable. I don't think you'll be too surprised by any of those. Right, now I'm going to leave metabolic disease there because we have got our great presentation from Professor Aya Pirinen next. So I'm going to move on and talk about neurodegenerative disease. So I'm going to mention brain vulnerabilities, mitochondrial features of neurodegenerative disease, metabolic disease and neurodegenerative disease. I'm going to say a few words about Alzheimer's, and then this afternoon we've got lectures from our great practitioners on Alzheimer's, multiple sclerosis and Parkinson's. Right, brain vulnerabilities first of all. So these are vulnerabilities for neurons, other brain cells, which are over and above the vulnerabilities for other cells in the body. So first of all, excitotoxicity. So as you will know well, this is pathologically high levels of neurotransmitters, particularly glutamate and NMDA. Iron dysregulation. Now this is a problem. Iron has been found in amyloid plaques in Alzheimer's and also in people with Parkinson's. And one of the best tests actually is using an iron chelator, and that improves the symptoms in several neurodegenerative diseases. So that's really useful to know. Copper dysregulation is not as common as iron, but does exist. Elevated intracellular calcium through the MAM dysfunction, that's the mitochondrial endoplasmic reticulum membrane. So this is a particular problem in the brain. And misfolded proteins. So I mentioned these earlier. Misfolded proteins tend to aggregate and stick to other proteins, as well as twisting out of shape. And they are fairly characteristic of neurodegenerative diseases, in fact. So they include tau and beta amyloid in Alzheimer's, alpha-synuclein in Parkinson's, and prions of mad cow disease. So prions are a particular type of misfolded protein because they can transmit the misfolded shape to the adjacent cells of the same type, which is a little worrying. This is known as seeding. And in fact, in effect, this makes the prion infectious, but without a microbe in sight. So scary. But it's not all bad news for the brain, because firstly, we have a lymphatic system, which works in the brain like a lymphatic system. It clears waste from the central nervous system, mostly during sleep, for the reason to get a really good night's sleep. And we do have neural stem cells, although it wasn't realized that we did have these for some time. So the neurons that die off can actually be regenerated. So it's not all bad news. So let's look at mitochondrial features then. So neurodegenerative diseases all show characteristics of mitochondrial dysfunction, plus the misfolded proteins and the inability to degrade those damaged proteins. Many of the problems, as I said before, implicate the MAM through poor calcium-ion regulation. And there you can see it, the mitochondria on the top, the endoplasmic reticulum below. And the ApoE4 genotype, which, as you know, predisposes us to cardiovascular disease and Alzheimer's disease, this increases activity of the MAM, which results in increased calcium ion dysregulation, in addition to release of mitochondrial DNA into the cytosol. And once you've lost your mitochondrial DNA, it's very difficult to get it back. So that's one reason why the ApoE4 allele is a problem. So let's look at the correspondence now with metabolic disease. And Alzheimer's has been called type 3 diabetes for very good reason. And that's because type 2 diabetes has been associated with a 50% increased risk of Alzheimer's. And that statistic, I really think, should be more widely known. Interestingly, though, although you have excess glucose in the circulation in diabetes, type 2 diabetes does manifest as a brain energy deficit. So it's like it's all gone in the circulation and none of it's getting into the brain. And brain energy deficit is an important pre-symptomatic feature of Alzheimer's. And type 2 diabetes is also associated with vascular dementia, Parkinson's and Huntington's disease. And type 1 diabetes associated also with increased risk of dementia. So there is a very tight correspondence there. So let's look at Alzheimer's. So you don't need me to tell you how rapidly the incidence is increasing. Horrific. Characteristics of Alzheimer's, well, it's basically the presence of amyloid beta or beta amyloid, you can see either, it's the same thing, and the neurofibrillary tangles, which are formed from hyperphosphorylated tau proteins. And it's quite useful sometimes to see a picture. So here is a normal brain, and here we've got the neurofibrillary tangles in the neuron and amyloid plaques around it. So Alzheimer's is a double prion disease. What does that mean? Well, it's because both amyloid and tau proteins can become prions. That makes it a double prion disease. So when does this manifest? Well, there's a very interesting post-mortem study here of Alzheimer's patients. And these are early onset disease patients. So higher levels of prions were seen at a younger age at death. And the prion activity correlated with disease severity rather than the amount of the plaques and the neurofibrillary tangles. So that was quite interesting. Happily, though, there is little indication that prions are implicated in late onset Alzheimer's as yet. Who knows what science may find, but at the moment, no indication of it. Mitochondria in Alzheimer's disease. So prior to disease onset, these patients show respiratory chain defects. Remember, I talked about the brain energy deficit, and particularly impaired activity of complex 4. And the early stages of Alzheimer's are marked by defects in axonal transport of the mitochondria. Remember, I talked about the mitochondria being clustered around the nucleus in the neurons, and then on the cytoskeletal tracts, the proteins would walk it down to the synapse for neurotransmission. Well, that's not happening in Alzheimer's, and consequently we have synaptic dysfunction on top of everything else. The degree of disability in Alzheimer's correlates with the level of bioenergetic impairment in the brain. And the mitochondria produce particularly high levels of free radicals, which is never good in excess. And hyperphosphorylated tau in the neurofibrillary tangles itself inhibits the mitochondrial function. And then, of course, as always, we have altered calcium dynamics, and particularly exaggerated release of calcium from the mitochondria into the cytosol. What's that going to do? It's going to trigger apoptosis. So I'm going to say a few words about Alzheimer's drugs. So conventional medicine thinks that amyloid accumulation in plaques is actually the cause of Alzheimer's, and it calls it the amyloid cascade of disease. So many of the drugs have been designed, virtually all actually, have designed to remove amyloid or neutralize it, prevent its action. And many of them are in fact antibodies. And they are very successful in doing that. They either remove amyloid from the brain or they neutralize it. Brilliant. But there's just one drawback. They don't stabilize Alzheimer's disease. And in some cases, they increase disease progression. Oops. So there have been more than 300 drug trials now, and virtually none were effective in even slowing Alzheimer's progression. That is not good. Two of the drugs that did help a little, Aricept and memantine, these help in slowing cognitive decline because they don't act on amyloid beta. Aricept is a cholinesterase inhibitor, and memantine reduces the excitotoxicity of glutamate. So you can see the logic behind those, certainly, but not for any of the antibodies. So then we have this headline on my BBC News feed: US approves first new Alzheimer's drug in 20 years. There's just one problem there. It wasn't a new drug. So it was in clinical trial and it was stopped in 2019 because it wasn't helping the antibody, it wasn't helping the Alzheimer's patients, and it was causing brain edema. This is not good. So the manufacturers reanalyzed the data. Never a good sign. And they said, oh, actually, a higher dose is going to work. But instead of insisting upon a new clinical trial, the regulators just licensed it. So now we're going to have still no improvement in Alzheimer's and more brain edema. Wonderful. What could possibly go wrong? So let me introduce you then to Professor Dale Bredesen, who will be familiar to many of you, I know. So he's published several studies on Alzheimer's, and he's written this great book, which I thoroughly recommend. It's really excellent. So he produced his RECODE protocol for Alzheimer's disease, and he is only a small trial, but he managed to get reversal of cognitive decline. So it's not often you see that in a trial heading, is it? Reversal of cognitive decline. So then this was so successful that he taught his RECODE protocol to a number of other doctors in the US, and they tried it with their own patients. So then they got together and they produced another paper with 100 patients and the same result: reversal of cognitive decline. Fantastic. And some of these patients even showed improvement in scanning results as well, and that takes some doing. So how did Bredesen achieve this? Well, he says there are 3 types of Alzheimer's disease. Type 1, driven by systemic inflammation. Type 2 is all the things we know well: insulin resistance, high homocysteine, hormone imbalance, lack of vitamin D, things we're doing every day of the week. Type 3, driven by dementogens. I love that word. Straight out of Harry Potter, isn't it? What he means by that is toxins and infections, microbes. So types 1 and 2 are strongly influenced by the ApoE4 allele, but type 3 occurs more often in those who are ApoE4 negative, but with at least one ApoE3 allele. So that's me. The Dementogens will get me. So type 3 tends to be inhalational, and it's a manifestation of chronic inflammatory response syndrome due to biotoxins. And I think I'm right in saying that this is a term coined by Dr. Richie Shoemaker, who's done a lot of work on Lyme disease and mold and various other co-infections. His great book, Desperation Medicine, which is worth buying for its title alone. So what did Bredesen actually do? Well, his approach is incredibly simple, and it's personalized medicine in action. Nothing else, it's that. So step 1 is determine which of the 3 types of Alzheimer's your patient has. Step 2, treat accordingly. It's that simple. And you all know how to do all of that because you're doing it every day of the week. Brilliant. So is there any support for Bredesen's clinical approach? Well, no, because conventional medicine is still saying there's no cure for Alzheimer's. But there is a study, a prevention of Alzheimer's study, and it's not using Bredesen's approach, but it does look at healthy lifestyle factors. So it's kind of a step in the right direction, but that's all that we've managed so far. Pathetic. So what does he say about the amyloid cascade hypothesis? Well, he says rather a lot. He's shown that amyloid beta is present in the brain and spinal fluid, cerebral spinal fluid, of perfectly normal, healthy individuals. Also, in post-mortem studies, he points out that brains have been found to be riddled with amyloid plaques, but these are people who died in their 90s with perfectly fine cognitive function. So what's going on? Well, his hypothesis is that amyloid beta is not necessarily neurotoxic. So what is it then? Well, he proposes that it's a protective response to a threat detected in the brain. And the threats can be all the things that we've talked about before. And he believes that amyloid is part of the innate immune system, it's antimicrobial, and it can bind some toxins. And this is why those drugs for Alzheimer's didn't work and made patients get worse, because they took the amyloid out of the brain or neutralized it. And what happened? There was now no buffer for the microbes and the toxins. Oh dear. So is there any evidence, independent evidence, that amyloid beta is protective? Well, actually, yes, there is. There's quite a lot coming through now, which is good. Is there any evidence that it's antimicrobial? Yes, there's evidence for that too. But none of this has filtered through to conventional medicine. So Dale Bredesen is not the only person who has something useful to say about Alzheimer's disease. Another person who's done a lot of research in this area is Dr. Stephanie Seneff, who will be more familiar to you probably from her work on glyphosate and aluminium, and more recently on COVID. But she's got a lot to say about cholesterol in the brain as well. So let's have a look at this. So the brain should contain 25 to 30% of the body's cholesterol, and this is mostly in the form of myelin. So myelin is comprised of saturated fats, cholesterol, omega-3 fats, and a few omega-6s. Cholesterol, what's more, is the limiting factor in the growth of synapses. It can also protect the brain from bacteria and viruses, rather in the way that amyloid can do. And a couple of researchers have actually suggested that we promote therapies to raise cholesterol levels in the brain. Well, you can imagine that went down like a lead balloon, can't you? And in fact, high serum cholesterol is positively correlated with longevity in people aged over 85. So what does she have to say about Alzheimer's? high serum cholesterol was associated with improved memory in those without the ApoE4 allele, and with reduced dementia, but only in those with the highest serum cholesterol levels. Alzheimer's post-mortem studies have found poor quality myelin sheaths, as you might expect, and a severe deficiency of fatty acids. Look at this, the difference in fat content, 28 micromoles per liter in non-Alzheimer's brains, 4.5 micromoles per liter in Alzheimer's brains. It doesn't get more clear than that, does it? So inevitably, she asks whether the low-fat craze could be partly responsible for the increase in neurodegenerative disease, and whether high cholesterol could in fact be a protective mechanism against Alzheimer's. So it's hardly surprising she's also got something to say about statins. So many studies have investigated whether high cholesterol is a risk factor for Alzheimer's. One found a correlation. This was just in males in their 50s, but Big Pharma have seized on this and promoted statins to protect against Alzheimer's. Nevertheless, a Cochrane review, which is the gold standard of reviews, and this looked at 2 large population-based studies, found that statins are not protective at all. And a very recent study, which I was delighted to come across, showed that statins more than doubled the risk of dementia in patients with mild cognitive impairment. And that came out this year. So she concluded from that statins increase susceptibility to Alzheimer's, and partly through lowering the natural healthy levels of cholesterol in the brain. Right, I seem to have finished. Thank you.
Wonderful. And also that. Just as wonderful as the previous presentations. We've got a couple of questions here, and we've got some extra time to do them, I think, as well. Yeah. Somebody is asking, can you expand on the topic of supplemental antioxidants not getting into cells?
Okay, I didn't say they wouldn't get into cells. What I said was they wouldn't get into the mitochondria. So whereas antioxidants might have a perfectly good role in the body and where they're getting into the cells, they won't be any use if you want them in the mitochondria, because they cannot penetrate the lipid bilayer. Sorry if I misled you there.
No, that's good. Okay. Somebody on Zoom is asking, do we know what we can do if someone is not getting into ketosis despite being on a keto diet for 6 months now? Client history of poor diet, overweight, losing weight but not getting into ketosis, very poor energy too.
You know, there's somebody much better qualified to answer that question than I am, and that is Dr. Sarah Myhill. So, shall I
give her a go?
Shall I take a microphone over?
Oh yes. Well, maybe we can. It's all right. That's coming. Yeah.
If they're not in ketosis, despite doing a ketogenic diet, then they're not doing it well enough. Everybody gets into ketosis if they reduce their carbohydrate content of their diet sufficiently. Now, it might feel very uncomfortable, and there's a condition I recognize, which I call ketogenic hypoglycemia. And the point here is that to fat burn, you need thyroid hormones. And if you are hypothyroid, you end up fat burning with adrenaline. And clinically, that feels like low blood sugar, because the symptoms of low blood sugar are not low blood sugar symptoms, they're adrenaline symptoms. So what that your patient may well be describing is ketogenic hypoglycemia. And I'd want to measure their ketones properly, either blood, urine, or breath testing. And B, I'd want to look at their thyroid function.
Brilliant.
Okay,
Thank you,
thank you.
Sarah.
Right. Another question. If someone is homozygous for the H63D gene, hemochromatosis gene, not one that I'm familiar with, I have to say, but have normal levels of ferritin and serum iron, except when taking high-dose vitamin C, would you suggest iron sequesters would still be helpful, as this genotype has been associated with higher risk of neurodegenerative disease, including ALS, due to elevated levels of iron in the brain? Did you get all of that?
Go. Next question.
Yes.
I'm sorry, I don't know how to answer that. Does anybody else have an answer? Oh, yeah.
Shide's offering.
Microphone, Dr. Shide Poria.
Behind you, Shide.
Right, yes, I would, because it takes a while for the ferritin levels to go wrong, especially in women who are menstruating. They lose iron regularly every month, but the levels will build up in the tissues. So if you don't find it, then you will accelerate the problem with tissue deposition of iron and therefore tissue damage from that deposition. So I would.
Brilliant.
Right.
I'm not a practitioner. I'm sorry. I'm a researcher. So I'm going to have to refer all these tricky questions to our great practitioners, but fortunately they're very well represented here.
We're doing well, I think. One more here says, Rachel, the ApoE4 mechanism and the cholesterol factor are linked, aren't they? Do you want to do that one, or?
I would have to do a little bit more research on that.
Okay. I would have had a go, but I don't have it all.
Please
No,
do.
No,
Okay.
I'll mess it up if I do it right now.
Oh, dear.
But I mean, the answer is yes. If I want a yes or no answer, it's definitely yes.
Yes.
And as I understand it, in reverse direction, so that the E4, which is the risk factor for Alzheimer's, is actually a better factor for cholesterol handling in the brain. Now, there was a gentleman somewhere who offered to come in on the earlier question of tryptophan versus melatonin mutation. There is behind you, Mark. Yes. Try to have a go.
Well, I would just give like a basic biochemistry aspect. I'm a pharmacist and an integrated medical practitioner. Simply, if you go back, tryptophan is a precursor to serotonin. Serotonin can be converted into melatonin. That's basic understanding. But the pathways where it goes to the pineal gland or whatever, under the influence of whatever catalyst comes in, it's a different case. But the cascade is simple. Tryptophan, amino acid is a precursor to serotonin. Serotonin can be converted to melatonin. Thank you.
Thank you very much. We still take one or two more from the floor.
Thanks, Rachel. Just curious if you, I'm trying to get my head around polyphenols. So they're supposed to have a slightly pro-oxidant effect in the body and thus stimulate nerve too.
Yes.
But also we get these studies, for example, about olive oil polyphenols protecting the oil from cooking at certain temperatures. Could you, I mean, is one antioxidant outside the body? Could you just clarify this discrepancy for me?
Yes, I understand the question. Polyphenols are working in the body via hormesis to a large extent. So they are providing reactive oxygen species to place the cells under a little bit of stress, which is beneficial for the future. But where they're protecting against the oxidation of, did you say olive oil?
Yes.
Okay. Well, that is to prevent the olive oil becoming rancid, which is a different mechanism. Are you with me? You're not. I can
Not
see.
quite. I'm still just curious as to how it can have an oxidative effect in the cell and antioxidant effect in olive oil, for example? I mean, surely if it's pro-oxidant, it's providing, yeah, doesn't quite make sense to me.
Okay, let me research it then. Leave your email address with Mark and I'll get back to you on that.
Great, thank you.
So would it be a good idea to give the guys a couple of minutes to get the professor lined up now?
Absolutely.
May take a moment.